fibrinogenemia. Shabana Nazir, a 7-day-old female baby resident of Hyderabad, informant being mother, presented with the chief complaint of prolonged uncontrolled bleeding from the umbilical cord stem since 2 hours. History of present illness: the baby was apparently asymptomatic since birth till 7th day, when the mother noticed bleeding from cord stem while changing baby's clothes. Bleeding was continuous, profuse, not controlled with application of pressure. There is no history of trauma, fever, pallor, swelling or redness or foul-smelling discharge from umbilicus. There is no history of melena, petechiae, hematoma, decreased acceptance of feeds or dull activity. There is no history of seizures, excessive cry or hematoma or bruise at the injection site. Antenatal history: mother was a booked case, took iron folic acid, went for regular antenatal checkups. There is no history of fever or any systemic illness or maternal bleeding episodes or drug intake. Birth history: baby was born at term by lower section cesarean section, cried immediately after birth. Birth weight was 3 kgs. Injection vitamin K was given. Baby was immediately given to mother and started on breastfeeds. Neonatal history: not significant till the baby developed this bleeding episode. Family history: baby is third in birth order, born to second-degree consanguineous marriage. There is a history of single umbilical artery and unilateral nephrectomy in sibling. There is no history of bleeding disorders in the family. Immunization history: baby is immunized as per age. Treatment history: baby bleeding stopped after giving fresh frozen plasma transfusion. This is a pedigree chart. Now, general examination: baby was crying with bleeding from umbilicus. There is no pallor, cyanosis or icterus. There is no facial dysmorphism or visible congenital abnormalities. Anterior fontanelle was open in 2 into 2 cm size. Posterior fontanelle was closed. No redness, swelling or around the umbilicus. Baby was pink, warm. Capillary refill time was less than 3 seconds. Anthropometry: weight was 2.8 kgs. Length was 51 centimeters. Head circumference 35 centimeters. Vitals were pulse rate 120 per minute, respiratory rate 32 per minute, temperature 36.8 degrees centigrade, and blood pressure was 60/40 mm of mercury. Systemic examination: CVS examination, first and second heart sounds heard, no murmurs. Respiratory system: bilateral normal vesicular breath sounds heard, no adventitious sounds. GIT: no cleft lip or cleft palate. Per abdomen is soft with no organomegaly. And CNS examination: no abnormality detected. Case summary: a 7-day-old female child born at term to a second-degree consanguineous marriage, third in birth order, presented with continuous uncontrolled bleeding from umbilical cord stem, otherwise active child with no features of sepsis. Differential diagnosis include classical hemolytic disease of newborn, hereditary clotting factor deficiencies, neonatal thrombocytopenia. On investigations, hemoglobin was 13.8 grams, total blood WBC count was 9,000 cells, platelets was 3 lakhs, hence ruling of neonatal thrombocytopenia. Prothrombin time was more than 100 seconds, normal 10 to 13 seconds. Activated partial thromboplastin time was more than 100 seconds, normal is 31-54 seconds. After FFP transfusion vitamin K, prothrombin time was more than 60 seconds, activated partial thromboplastin time was more than 100 seconds. And again, after on 11th February, platelet counts were 3.5 lakhs per cubic milliliter. Bleeding time was 3 minutes 10 seconds. Prothrombin time was 100 seconds. Activated partial thromboplastin time was 200 seconds. Thrombin time was 240 seconds. Normal is 20 seconds. And fibrinogen level after FFP transfusion was 27 milligrams per deciliter. Normal is 200 to 400 milligrams per deciliter. So prolonged prothrombin time, activated partial thromboplastin time, thrombin time, and low levels of fibrinogen are consistent with congenital afibrinogenemia. Now, fibrinogen is a glycoprotein synthesized by liver. Normal plasma concentration is 200 to 400 milligrams per deciliter. Half-life is around 2 to 4 days. Functions are fibrin clot formation, platelet aggregation, prevents excessive clot formation by binding plasminogen. Congenital abnormalities of fibrinogen are of 2 types. Type 1 usually inherited as autosomal recessive. Presence has bleeding episodes either spontaneous or after trauma. They include congenital afibrinogenemia, congenital hypofibrinogenemia. Type 2 inherited usually as autosomal dominant. Present either as bleeding or traumatic events. It includes congenital dysfibrinogenemias. Congenital afibrinogenemia, incidence is 1 in a million with equal sex ratio. Can present as umbilical bleeding, epistaxis or oral mucosal bleed, gastrointestinal bleed, hematoma after vaginal delivery, menorrhagia, postpartum hemorrhage, spontaneous abortion, stroma and surgical bleed, rarely intracranial bleed, hemarthrosis. Bleeding in brain is the leading cause of death in these patients. Afibrinogenemia is transmitted as autosomal recessive with an incidence 1 in million. Fibrinogen levels less than 10 milligrams per deciliter. Lab findings show markedly prolonged prothrombin time, activated partial thromboplastin time, and thrombin time. Hypofibrinogenemia is transmitted as autosomal recessive and dominant with an incidence less than afibrinogenemia. Fibrinogen levels are 10 to 200 milligrams per deciliter. Lab findings show normal activated partial thromboplastin time, mildly prolonged prothrombin time, and thrombin time. Dysfibrinogenemia is transmitted as autosomal dominant and recessive with an incidence of 1 in 1 million. Fibrinogen levels are usually 150 to 300 milligrams per deciliter or normal. Lab findings show normal prothrombin time, activated partial thromboplastin time, and prolonged thrombin time or repilase times. Case reports: till now around 250 cases of congenital afibrinogenemia have been reported worldwide. In India, Gujarat Medical Journal has published a case in February 2011. Italian Journal of Pediatrics has published a case in 2010. Take home message: congenital afibrinogenemia is a rare bleeding disorder diagnosed by prolonged prothrombin time, activated partial thromboplastin time, thrombin time, low fibrinogen levels in the absence of consumptive coagulopathy, and sequence analysis of FG, FGB, FGG genes confirm it. Prenatal diagnosis: pregnant females with a family history and history of consanguinity should be counseled. If mutation is known, genetic counseling testing is done in early pregnancy by chorionic villus sampling. Cord blood testing may be offered to babies born to suspected carrier patients. Treatment: hemostatic level of fibrinogen is more than 60 milligrams per deciliter. Symptomatic bleeding episodes are treated with fresh frozen plasma, cryoprecipitated virus inactivated fibrinogen concentrates. Prophylaxis: avoidance of intramuscular injections, traumatic intervention, screening for intracranial bleeds at birth. Prophylactic infusions of cryoprecipitated have been employed after life-threatening bleeds like IC bleeds. There's a picture of the baby before discharge. Thank you. Bleeding, like in DIC. Whereas here, there is nothing like, and the mother did not take any anticoagulants or heparin, something like that, or did not take any drugs, and the baby was not given anything except vitamin K, that's it.
Disseminated intravascular coagulation, Sir was asking, consumptive coagulopathy. To exclude, for example, this case has presented with prolonged prothrombin time and thrombin time, and there is a decreased fibrinogen level. Sir is asking, how are you going to exclude disseminated intravascular coagulation? Suppose in this case, baby has presented soon after birth. Soon after birth, baby has presented with a cord bleed, is it not? If had there been early neonatal sepsis, the child, don't say no. If they're suspecting there is a possibility of early neonatal sepsis, how are you going to differentiate that from this congenital hypofibrinogen? That is the question.
Thank you, sir. Sir, there are no features of, normally conjunctive coagulopathy, there are features associated like inflammation. DIC appears in inflammation or any infection. Like there are features like decreased acceptance of feeds, and there are features like temperature variation, and there are dull activity and seizures. All these were absent. The baby is quite normal except for prolonged bleeding. That's it. Thank you, sir.